Thank you. It's so great to be here with everybody today. When we first started talking about this event a few months ago, I don't think we really could have hoped for a better turnout and a better lineup of presentations and so forth. So thanks again for being here today. My title of my talk today is meant to be a little bit provocative. We are in the midst of an opioid crisis. We are seeing methamphetamine rates rising incredibly as well. But I just want to keep bringing our attention back to the fact that alcohol continues to be one of the most destructive elements in our culture right now. It's been around for a long time. It's widely accepted, widely available, ubiquitous. The only thing we've ever really tried around alcohol was prohibition, that we responded as a nation and said alcohol is a big enough problem, we need to do something. Well, what do we know about prohibition? It didn't work, right? It didn't work. And one of the reasons it didn't work was because it was so absolute. It was a yes or no. It was a very polarizing decision. What we know about the Just Say No campaign with drugs is that that has not worked. So what we're doing more now is really talking about harm reduction strategies. And a big piece of harm reduction strategy is learning about what is the true information about the substances and how can we make good decisions based on the pros and cons and the consequences and the benefits. Alcohol is a drug because it's a psychoactive substance that has both benefits and consequences. Some of the benefits a lot of people enjoy and have no problems with, but many folks have consequences both from overuse and then having a substance use disorder. The other thing we do that is a harm reduction intervention is working in systems. So we have ages where you have to be a certain age before you can buy alcohol. We have rules about not driving while you're drinking, so things that reduce the harm that we know are attached to the use of alcohol. Again, it is the most destructive drug, but I learned a phrase last night that helped me understand how to describe this. Right now with the opiate crisis, we have a mortality crisis. People die very quickly from the overuse of a narcotic. They're dying of overdose. And they're dying at young ages and with a relatively short period of time of abuse of the substance. With alcohol and with some other substances, what we see is a morbidity issue, which means that there are a lot of health conditions associated with the use of that drug that then cause death. So when we look at this graph, alcohol versus opiates, alcohol has caused more deaths, 88,000 versus 72,000 with opiates. But that 88,000 comes in long, slow, painful deaths, and with folks that are older than the ages that we're seeing in the opioid crisis. But we've also seen deaths by alcohol really taking a turn up on the graph. Deaths by alcohol for women have increased by 67%. So the overall increase is 35%, but for women it's 67%. That's reflecting two things. It's reflecting that women are much more likely to be using alcohol at higher rates, and women are much more vulnerable to the health effects, the health consequences of alcohol. I'm going to be talking at greater length about that later in the afternoon if you want to come to that session. So the men's rates are up 29%, a little bit lower than the overall average, but still that's shocking, a 30% raise. Not just deaths by health problems, but we also see deaths and consequences in a lot of other arenas. So we see accidents, we see assaults. Suicide is a major cause of death in alcohol problems. Suicide, when you look at completed suicides, about 1/4 of folks at their autopsy have alcohol in their system. About 1/3 of them are legally impaired at the time of their death. So alcohol is a co-factor in a lot of deaths in a lot of different ways: accidents, suicide, and health problems. So those are some of the personal impacts of alcohol. But we also see that there are a lot of impacts in our culture from alcohol. And one thing that you hear this known as is bystander harm or secondhand harm from substance use. So what we see from secondhand harm is that it's not my use of substances that are causing problems, it's my college roommate who pukes all over the floor and I have to clean it up. It's my friend that I have to babysit home from the bar to make sure that they get home safely. It's getting into a fight with somebody who is drunk and not making any sense, who then assaults me physically, or insults me, or abuses me in some other ways. So there's lots of ways that bystander harm happens. And when we look at breaking it down in who's hurt in what ways, women are mostly hurt by family members, by partners, by people that they love. Men tend to be hurt by strangers. Think your average bar fight. And then drinkers tend to be hurt by other drinkers. You know, have you ever heard the saying, nothing good ever happens after midnight? It's because people are out drinking. Everybody that's out after midnight probably is in some way intoxicated, and those kinds of harms happen with each other. To illustrate this a little differently, let's take a look at this chart. And I know you can't see it super well, but what I want you to see is that top line, which is the harms done by alcohol that are done through our communities and then personally. So what is the community impact of the use and abuse of alcohol, and then what's the personal impact? And you see that alcohol far and away is the #1 drug in that combination of community harm and self-harm. Alcohol is #4 in self-harm, in the harm to self, right after heroin, cocaine, and methamphetamines. But it's #1 in the social impact, and by quite a bit. We know that the harm that's created in our culture by alcohol is twice the amount of harm that harms self. So it's a very destructive drug, and yet we use it a lot, and it's widespread, and it's just commonly accepted that folks drink. Well, so how can we take a look at what are safer levels of drinking, and how can we help change the perceptions and the beliefs about drinking, and what is harmful levels? Certainly it's a harmful level if you assault somebody when you're intoxicated, right? But it's also causing health harms if you're drinking above certain levels. There's a little bit of controversy about even calling it lower risk, because the reality is that any use of alcohol is risky, just like the use of any substance. But the research that is being shared now through public health channels is about levels of use that can be seen as the least risky for folks if they are going to choose to drink. I did not know this. Did you know that the Dixie cups are marked with amounts for the different kinds of drinks? So at the very bottom, it's a 1 ounce mark for liquor, for hard liquor. There's a line for wine, there's a line for beer. So one of the things that we start with is that most people don't know how much they drink or even what a drink is. So they might say they have a couple of beers, but it might be a 40 ouncer, right? So you have to really start digging in on what are you drinking and what is the alcohol content. Microbrews have alcohol contents all the way from 4% up to 12 or 14%. So we need to figure out what those are and then how to change the amounts that folks are using. The standards are different for men and for women. For women, it's no more than 3 drinks at a sitting. For men, it's no more than 4. For women, it's no more than 7 drinks a week. For men, no more than 14. And again, those are because of changes and differences in men and women. We also see that lower end is applicable to folks with brain diseases and folks that are more elderly. Well, how many people follow those kinds of levels of use? Here's another graph that you can't see real well, but you can access these slides later. But what you can see is the way that range works. So up to 60% of people don't drink alcohol at all or drink less than 1 drink a week. That's a majority of our adult population. This is ages 12 and up. So then you get to the 60s and 70s%, and those folks are drinking less than 2 drinks a week, 2 to 3. And then you get to the folks in the 80 to 90 percentile. Those folks are averaging about 2 to 3 drinks a day, or 12 to 14 drinks a week. Kind of within those safer guidelines, but pushing up against it. Now look at that last decile. That last 10% of the people drink the majority of the alcohol in our culture. And they're drinking way above safe limits. And in fact, some of those folks, the average goes up to about 10 drinks a day. So imagine if that's the average, how high some folks are drinking. Those are the folks that normalize alcohol in our culture. Advertising is targeted to those folks to get them to brand loyalty, to also normalize daily drinking, and to normalize heavy drinking. So that's who advertising is aimed at in our media culture. When you ask most folks who don't drink at all, they'll say, oh yeah, everybody drinks, but I don't. Or I only drink 1 or 2 because I'm a lightweight. Actually, looking at this graph, we see that most people are lightweights, and it's the heavyweights that are in a minority. So what do we do about this? Well, first of all, we address stigma. There's a couple of differences in stigma. Certainly there's a stigma of being an alcoholic, of being a drunk, of being a wino. There's a lot of negative connotations to that. There's also stigma that the drinking community can turn on the non-drinking community. So there's a subtle or not so subtle pressure to drink at least as much as, or to drink with me. How many of you have been pressured to drink at a party even though you weren't, you turned it down initially? So the stigma also exists in that there is a continuum of alcohol problems. It's not just either alcoholism or no problem at all. It's that there are problems all the way along that continuum, and some of those problems can be addressed by reducing use, by just cutting back, by changing strategies for stress and coping skills. But when we think about going in for treatment for alcohol problems, or if we even think that we might have an alcohol problem, we're sort of scared to even talk about it, because we know that treatment for alcoholism means spending 30 days up in Estes Park and then coming back and staying sober for the rest of your life and going to those damn meetings, right? That's for a small percentage of folks that have alcohol issues, but it scares us from even talking to friends or family or our doctors about drinking issues. Again, we want to share facts about the risks and benefits. The best youth prevention is delayed onset. As long as we can delay that first drink, the first use of alcohol, exponentially folks are less likely to develop alcoholism. The regression of the mean is around age 22. So if they don't have their first drink until 22, they have about a 6% chance of developing alcoholism. If that first drink is back at 12 or 13, it's about 65%. We want to intervene early, talking to people about safer drinking levels so that they don't go on to develop a substance use disorder. And then finally, using evidence-based programs. Not only do we have programs that work, cognitive behavioral strategies, motivational interviewing, there's also pretty effective medication-assisted therapies for alcohol. And when we talk about MAT, we're usually talking about opiates. But long-acting naltrexone, a 30-day injectable that is marketed as Vivitrol, has a very high success rate with chronic alcohol use disorder folks. And so that can be a drug of intervention that can be done through your doctor's office. It can be done in conjunction with counseling or not. So there are interventions that we need to start looking at. So the take-home message is that we really want to prevent alcohol use disorder problems as they begin. We don't have to wait for people to hit bottom. We can give them information about moving into risky levels of drinking and help them change. So that's the early intervention part. we do know that treatment works, and a lot of us have examples where we sent the family member off to Estes Park and they didn't end up coming back sober. What happened? Well, those are the anecdotal episodes, but we see traditionally or over the long haul, folks are actually more compliant with drug and alcohol treatment than they are with blood pressure medication or diabetes. And it's a chronic illness that needs repetitive treatment and consistent treatment over time, not just a one-time episode of 30 days of treatment. And then finally, recovery happens. We have a lot of folks in this room that are in long-term recovery. I myself am in long-term recovery. And I was talking with a physician who's here today who said, you know, I don't always reveal that to people because I don't want it to get in the way of our treatment. But the fact that we've been talked about being anonymous in our recovery, I think has limited the impact that we can have on other people in sharing that there's lots of folks around that have indeed recovered from alcohol use disorder. So let's just keep remembering that alcohol continues to be a problem. It co-occurs with most drug problems, and it's very treatable, and just very simple changes can make a difference. Thank you.